we're gonna give people a minute to filter in. And Jeannie, we can barely see the ear of your cat. You want to give us what's the cat's name? Look, you're muted.
Margie Grace, and she is thinks it's her lunchtime snack time. She may reappear.
All right, well, Margie Grace is an unannounced panelist for this particular VentureCrush, which we
She thinks we
do.
should invest in cat food.
Okay, appreciate it. All right, well, thank you everyone for joining, and welcome to a mid-August VentureCrush. We appreciate people actually taking the time to participate in this. And we're going to talk about, as advertised, this is health tech and equitable health access. I am confident that the Dobbs decision will also be referenced. So if you would rather not hear about reproductive rights, if you would rather not hear about the deprivation of reproductive rights, then you can always opt out. I will also disclaim that any view I express is only my view. That will not be the bulk of what we discuss. I'm just mentioning it because it will be part of what we discuss. And the way that we would like to start is we'll give you some bios and background info in series on our amazing speakers, their bios. There are links to their bios in the chat. We would love it if you had questions for the panelists. You can drop those in the chat as well. We'll try to get to them. We want to thank our Lowenstein colleagues, Kelsey Repka, Latoya Bethune, and Shelmy Ulis for their research on today's panelists, which will make us sound smarter about the panelists. The mistakes will be all mine and unlikely to be Meredith's at all, but thank you to the three of them. And while you're in the chat, we'd love for this to be an opportunity for folks to connect with one another, introduce yourselves, use your LinkedIns in the chat. And with that, just two other quick pieces of housekeeping. One is that we have our VentureCrush Americas kicking off on October 11th, which is focused on the Latin America and Hispanic Latinx communities in venture and tech. And there'll be a link dropped so that folks can register for that. We're really excited about that. And there's also a Twitter thread that will be dropped in the chat if it hasn't already been, on some of the amazing work that Professor Dr. Mandelblatt has done regarding access and aging and cancer and the undercoverage of women and of women of color. It is an extraordinary career, and we thought that for our community, people probably know Maria pretty well, since she's gotten a tremendous amount of press, having recently raised the single largest women's health venture fund ever raised anywhere in the world. So congratulations and thank you for doing that, Maria, which is Steel Sky. And we also know that Regina Benjamin is a household name and a return guest for VentureCrush, which makes us really happy. So with that, maybe we could do a little bit of Maria's background, then Jeannie's and Regina's, and then Meredith can talk a little bit, and we'll get into the fray from there if that works for everyone. All right, so Maria, I know that I want to talk a little bit about mac and cheese. Do you want to tell people why I want to talk about mac and cheese?
Well, Probably you're referring to my summer internship program when I worked at Kraft, and I was asked to increase the margins of the mac and cheese cups. And so I was the inventor of the extra large Easy Mac cup. So if you're going to the shelves and you're overeating on mac and cheese and getting too much sodium, you have me to blame for it.
So you've been making up by investing in health ever since. It's like your
Yeah,
penance. Okay.
exactly. After feeding all of this, sugar and sodium, I felt like I owed it to the world to try to prevent pre-diabetes, diabetes, hypertension, and other health concerns.
Having caused some of it
Yeah.
directly through just adding more mac and cheese in everyone's cup. Okay. And you also started a company in college, and I was recently, I had the privilege this past weekend of attending Lola West's 75th birthday party. And a number of the people who spoke and praised her talked about how she was the first person who asked them what they wanted their legacy to be. And I think that's an interesting question for the folks on today's panel. And one of the interesting things about what you have accomplished is you founded a company in college 20 years ago, maybe slightly more even. And that company was acquired, and amazingly, it is still up and running, which is part of your legacy. Does that shape how you think about the impact that you want to have and the ability to leave a legacy behind?
Yeah, I think that early success gave me the confidence that I could build something that could leave a legacy and I can build a sustainable business. And I wanted to take that from just creating a great business model that is sustainable to creating something that I wanted to leave in the world to make it a better place. And so that's why I started a healthcare fund. That's why I wanted to focus on women's health, because I thought that's a place where I could really make an impact and leave a legacy. And being a part of pioneering investment in women's healthcare and pioneering investment in life-changing companies for women is something that's really important to me. And I'm so happy if that's the legacy that I leave behind.
Amazing. Can you talk a little bit about Mary T. Christian?
Yes. So my first inspiration in life was my grandmother. And so I like to tell the story when most people are thinking about their grandmothers, they're like baking cookies together or reading books. And my grandmother was a politician, one of the first Black politicians in Virginia post-Reconstruction. And so instead of baking cookies, I was knocking on doors, participating in campaigns, traversing Hampton, the town of Hampton, at churches and going around with political leaders. Also served as a page in the Virginia House of Representatives when she worked there. And so she was really inspirational to me in creating change, because she wanted to create change in her community. She wanted to make change and make it better for Black people in her community, underserved people in her community. And I think you can see from the work and my career trajectory, I've adopted a lot of those principles, and that's where the inspiration came from.
That's awesome. And she worked, am I right that she started in the laundry room at Hampton University and
Yes.
ended up where at Hampton?
As the dean of the School of Education. So back then, her friends, Katherine Johnson, all of the hidden figures were kind of her friends. Katherine Johnson was my mom's Girl Scout leader. And so she was kind of in that cohort of women. She actually served in the cafeteria. She served them, Katherine Johnson, when they were working there. And then she moved to working in the laundry room at Hampton University because she couldn't afford it. And then somebody saw her there and they thought, she was smart. So she signed up for a typing class. And so she took a typing class. And then she went on to be a student at the university and then went on to eventually become the dean of the university. And if you're out in the garden, they recently commissioned a bronze statue of her that sits in the garden for all of her contributions to Hampton, the city of Hampton, and also the university.
Extraordinary legacy, and thank you for sharing that. I am, however, a little sad to hear that someone had to first spot her, because that speaks to the overarching issue of access and of who's hiding the hidden figures and who has to work to unhide them and create those on-ramps. Speaking of which, Regina, I see you just leaned forward, so you might as well unmute yourself. And
I was trying to read.
there are so many descriptors and accolades, from a medal awarded to you by the Pope, to the MacArthur Genius Award, to having served as the Surgeon General under President Obama, to the endowed chair you hold at an HBCU. But one of the stories that I kind of particularly like is a story you and I haven't talked about in years. But can you talk about having been rejected by Yale Medical School?
Oh, when I was in college, I mean, not college, I was in high school, I knew I wanted to go to college. I grew up Catholic, education's important, particularly in the South. But I knew I wanted to go to college, so I applied to colleges, and I didn't know how to apply. So when I took my SAT, it said, what do you want to be? And I didn't know. I looked down the list and I saw international lawyer, and I thought, that's interesting. I don't know what it is, but it's interesting. And so I checked it off and sent my application in. Then I just said, well, if I'm going to be a lawyer, I need to go to law school. So I applied to Yale, and I sent this little application or whatever to Yale, and I got this nice letter back from them that said, thank you for your application. However, we suggest you go to college first. And so I didn't go to Yale. I decided, well, if they don't want me, I'll do something else. But I didn't even know I had to go to college before I could go to Yale Law School. So, but I applied to the law school, not to the college.
But it is the unbridled aspiration that I think is great. And how did you end up going from trying to skip all 4 years of college and applying straight to law school while in high school to ending up going to medical school?
Well, I went to Xavier University in New Orleans, and education and just pre-med was the biggest club to join, and everybody just joined clubs. And I'm a joiner, I'm a people person, so I joined the pre-med club. There was nothing special about it. It was like everybody was in a pre-med club. And so that's how I got introduced. And as couple of years went on, you do things to prepare for med school and whatever. And I was in medical school like the second year before I realized that I want to be a doctor. There's nothing else I want to do, because I was always, achieving and whatever. And I came up with organic chemistry, which many of you know, and it was like I made a B, and I thought that was the end of the world for me. And that's when I knew I wanted to be a doctor. And since that time, it was like that was the only, that was what I wanted to do. And I always say it's divine intervention. It wasn't me trying to achieve something. It was where I was supposed to be. And so that's why I went into solo practice in this small town for the last 30 years.
And when you say solo practice in this small town for the last 30 years, were you surprised that as a general practice, small town in Alabama physician, were you surprised when you got tapped to be the Surgeon General?
I started being active in the American Medical Association when I was a student and a resident. And so I always was in the policy side of healthcare. And I kind of grew up with that. And I learned that you can make a difference by being, when you come together as a group and do things. And so I learned that. So I had already been kind of on the national stage a little bit. And I was in solo practice, as I said, for like 22 years. And so, yes, it was a surprise because I didn't have anybody to run my practice. And so it wasn't something I was thinking of, but I wasn't uncomfortable because I had done the health policy stuff. I testified in front of Congress before, and I'd done some of those things as a student and resident. So.
And in fact, you were chair of the AMA Council on Ethical and Judicial Affairs from 2008 to 2009. So you were you had a major role on a national platform at
Yeah,
that time.
that was the second thing. The first thing was that I was the first African-American female to be elected to the Board of Trustees, but I was also the first person under 40 to be elected to the Board of Trustees. So those things had already given me a little bit of a platform in the AMA and nationally. But then after I came off the board, CJA, as it's called, the Council on Ethical and Judicial Affairs, we maintain the code of ethics for the profession of medicine. So when we write the policies and the procedures that the licensing boards and the others hold physicians accountable for when it comes to ethics and the medical professions, regulatory and disciplinary actions.
And we have some real ethical issues in judicial affairs regarding medicine and health right now. Do you want to talk about one or two challenges you are seeing?
We've always, not always, yeah, we've always had those challenges. And as physicians particularly, we always say we should keep the patient at the center of everything, and the patient comes first. And it's very difficult in today's world to understand that I will put my patient before I put myself, and my patients expect that. You know, there are some limitations there, but that's when we have that patient-physician relationship, that's a bond that we have, and we consider it sacred. And you have an ethical obligation to do the best you can for that patient at that moment in time. And not for the whole world, but for that individual patient at that moment in time. And our patients expect us to do that, and we should.
And is that bond part of why 5 feet of flood water wasn't going to stop you from going out and making house calls during a disaster?
A couple of disasters, Katrina, two other hurricanes. It was the right thing to do. You know, it was the one thing is that patients were there, and we all were in it together with the hurricane. And as people may not know, but during Katrina, our town has 2,500 people, 2,000 lost their homes. And so they needed care. So I was there, others in the community helped me, and we just kept things going as needed to be. You know, people didn't have medication, so I took a piece of whatever, copy paper, cut it in 4 places, and wrote prescriptions and asked the pharmacist to bill me. I had no idea how to ever pay for it, but I knew that I had a better chance of getting it paid for than they did. So, but it all worked out fine.
And that was Katrina. You also got hit with Hurricane George, and then your clinic years later was destroyed by
fire. Yeah, it was burned to the ground. And you know, again, I say divine intervention. It was tough, but again, the people in the community didn't have homes at all. And when ours burned down, it was that we were trying to reopen after rebuilding, and the day before New Year's, it burned to the ground. But over time, things happen for a reason. We got a new building. It took 4 years, but we got a new building, and so things worked out. We never stopped seeing patients. I saw patients out of my truck. And we got a trailer, and so we never stopped.
And last question for you before we turn to Professor Mandelblatt. Can you talk about, there's a relatively new organization that's one of many that you have co-founded, or you're co-founding board member of, that is dealing with health equity, which is a topic that runs through so many of the projects and organizations that you're involved in. This one is Black Directors Health Equity Agenda. Can you talk a little bit about that? Yeah,
actually there are 2. That one's one, the Black Directors Health Equity. During the early days of COVID, we were hard to get PPP, the protection gear, and trying to get things to communities, particularly in Black communities, particularly in the areas where it was hard to get these supplies and things. And so many of us who were on healthcare boards of directors kind of started coming together on Zoom and saying, what can we do? Can we get something from our health systems? Can we get some supplies? And that's kind of how we started it. And we realized that it was much bigger than just the supplies. And so we formed this organization of Black Directors Health Equity Agenda. And we're focusing on health disparities. We have an area around education and different areas. And we have a conference coming up in September, end of September, early October at Morehouse School of Medicine. So if anyone's interested in attending or joining by Zoom, it's you can Google it. The other organization is a nonprofit called Direct Relief. And Direct Relief, I've been involved with since Katrina because they helped me when we were in Katrina. And it's an NGO that usually does work around the world when there's a disaster, and it's a disaster relief. But Mackenzie Scott donated the largest amount at her first round to Direct Relief for health disparities. And so we have that fund, and we started trying to find organizations, particularly small organizations on the ground that are doing work that oftentimes don't have the infrastructure or anything for basically general operating. They're out there doing the work. We're trying to get funds to them. So if any of you know those kind of organizations, let me know. We want to support them and the work that they're doing. And we have some wonderful organizations over the past year and a half that we've donated to, but we got another cycle coming up. So would love to get any recommendations you have.
Amazing. Really appreciate you spotlighting those organizations and all of the work that you do, and it continues to be a privilege to be your partner in First Close Partners, of which you are a co-founder and investment committee member, and through which we invested in Maria's fund, Steel Sky, and about 90 others. But we'll talk a little bit more about that later. And let's switch over to Jeannie, because the concept of access and folks who don't have access to expert medical care is something that has run through the entirety of your career, Jeannie. It seems like it's been a motivating factor. So you get out of Columbia Medical School, and you immediately, I know you did not grow up with money, and you immediately take the highest paying job available to you. Where did you work right after Columbia?
I first did my residency in the residency program in social medicine because my commitment was as a physician, as a social change agent. I felt from the beginning that my key role would be as an advocate for my patients on all levels, and that being in the community was a really key part of that. And my first job was at the Berecan Neighborhood Health Center in East Harlem after my residency.
And is it accurate that in the very late 70s and into the early 80s, you were the most active provider of OBGYN services or gynecological services in Harlem and East Harlem for several years?
Yes, I trained in family medicine, and I was taking care of generations of families and providing all the OBGYN care to the women there, taking care of those children, taking care of the grandmothers. And it was a wonderful, wonderful experience. And I learned a lot about intergenerational healthcare, intergenerational trauma, and intergenerational resilience as well.
And you also were there seeing the first wave of the AIDS epidemic.
Yes, yes. And it had an amazing impact on many of the women in my practice. And I remember many of those women who had gotten AIDS, and it's was something that I still carry with me, and I remember each and every one of them. And when I later, as providing GYN care to older women, noticed a variety of health and cancer issues that I had not anticipated, I was researching why there was something about aging that was decreasing your ability to fight these infections in the same way that HIV was. And HIV, early in the HIV epidemic, cervical cancer was included as an AIDS-defining cancer, and there are many, many of them. And interestingly, now AIDS has become persons living with HIV live nearly normal life expectancy, and ironically, living with chronic immune disorders and acceleration of immune aging, these individuals are now developing cancers at very early ages that you would normally see in a much older person. So that lung cancer is a key cancer in the 50s of persons living with HIV now. And that's a part of my current cancer and aging research.
And before we get to that research, which I know we're also going to talk more about in the second hour, you were offered a job in Queens, and you said that you would only take the job if you could continue your pediatrics and OBGYN work. Can you tell us a little bit about what happened then? And this is in the early 80s, mid 80s?
Yes, early 80s, early to mid 80s. This was sort of a serendipitous beginning of my research career. I went to medical school planning to work in the community. I never envisioned becoming a researcher or specializing in something like cancer and aging. But the director of ambulatory care had directed this public hospital in New York City for 25 years, all of their outpatient services to men and women. And when I said I wanted to do gynecological care in his clinic, he said, "Oh, you can't do that. There are no stirrups on these tables." I looked at him and I looked at the table, and many of you might remember those metal stirrups, and I pulled them out and flipped them open. And I said, "I guess we've got a deal." And that was, in fact, the beginning of my research career, because I noted a lot of cervical cancer among these older and older minority women that I was caring for. And I set it up to teach interns and residents on how to do gynecological care and how to do women's health, which had not been a focus. And I took notes on index cards, feeling somehow just having the idea, de-identified data on all of the patients that we cared for. And when I noticed, gee, there's a very high rate of cervical cancer here. Something's going on, either aging, no prior access to pap smears. And I analyzed those data from my index cards. It led to my first publication, which was in JAMA in 1986, looking at pap screening for older women. That was the start. So those stirrups were the start of my research career.
Amazing that he was running this for 25 years and had no idea, which I think is just
no idea about that women's health was part of internal medicine. No clue.
And that's a theme that runs through Maria's investment thesis. So I'm going to bring Maria back in, and then I want to come back to pap smears. But Maria, you were asked about the next big area in healthcare, and you talked about women's health and menopause. Do you want to talk about the investment areas that are particularly interesting to you and the underfunding?
Yes, I mean, as we know, all of women's healthcare is underfunded, getting less than 4% of investment. And, I would argue it's one of the biggest growth opportunities and investment opportunities. And what I like to say is whether, it's a pandemic or war, no matter what's going on in the world, women are still going to menstruate. They're still going to give birth, and they're still going to go through menopause. So these are things that don't stop. And so that's why we feel really confident in our ability to continue to find companies that can sustain through any market environment. One of the areas that we really think is underfunded, where a lot of opportunity lies, is in menopause. And so we've been investing in companies that can help service this community. Over 1 billion women are going to be experiencing menopause in the next 4 years, and there's nothing on the shelves for them. There's no tools, there's no authoritative source for people to go to. Most women don't even know that are in perimenopause. They don't know what that means to go through menopause. They don't know the symptoms. And so there's a lot of opportunity to not only educate, provide resources, provide solutions that just haven't been created. And so we're excited to be able to invest in companies that can provide solutions. In addition to menopause, we think that's, a great spot as well, but also, maternal health, we've been investing in, a lot as well. And as we know, it's a national crisis, and people talk about the rates, and we know that there's disparities with, in from Black and Hispanic, and they talk about the rates being 3 to 4 times the maternal mortality rate is 3 to 4 times that of white women. But what they don't talk about is in New York, you're 10 times more likely to die than a white woman if you're Black. New Jersey, you're 8 times more likely to die if you're Black. Those are really concerning numbers. 3 to 4 is already concerning, but knowing that the state that you live in, when your friend goes to give birth, it's a very high likelihood she might have a poor outcome. And I just don't, that doesn't sit right with us, our fund. And so that's another reason why we're investing in solutions for Black maternal mortality and for underserved communities, and doing work also around how that they have access in rural communities to maternal care as well.
There is so much in what you said, and I want to ask Regina and Jeannie to jump in on this, but I also want to just note that, and this is on the Twitter thread that I did last night on Professor Mandelblatt's work. In 2004, she published in the Journal of Clinical Oncology an article on benefits and cost interventions to improve breast cancer outcomes in African American women. That's 2004. She's also got publications from the late 80s and 90s on African American women and cancer. And that article noted that despite the lower incidence of such cancer among Black women in the study, they were dying at a much higher rate than their white counterparts. And that speaks to the cancer care. And Regina, Maria just highlighted this duality of, we talked earlier about how care wasn't as available in Alabama, and we think of, care deprivation or access deprivation in rural communities. And here Maria is spotlighting this 10x mortality problem in New York City, arguably the epicenter of great medical care in America. Is that reflective of other urban areas of other major cities in America?
Jeannie can answer that, but yes, it is. And in rural areas, just getting early access is challenging anyway. You would think that people in New York City would have better access and better outcomes, and they don't. So the rural areas are even worse. And by the time they do get treated, it's late. It's often late. It's often kind of, and technology and newer companies hopefully can improve that. I think Maria, go ahead, Maria.
Yeah, one of the things I wanted to say is it's not only low income women. This is people with graduate degrees are dying at higher rates. So it's not that they can't afford care, and these people can afford the best care, but because of medical racism, these are the reasons for the outcomes. It has nothing to do with your socioeconomic, which I thought was really enlightening when I actually saw the data on how people, and we've also seen the stories about Serena Williams and other celebrities, and this is not low income women, this is not socioeconomic, this is medical racism, and it showed in the data. And so that's really what we need to be talking about, because sometimes it's not about access, it's just about racism. And so how can we change this in the healthcare system, or how can we match women with doctors that are going to take them seriously, take their concerns and their health seriously? And I'm sure Dr. Mandelblatt, you have some thoughts on that.
Yes, I have lots of thoughts on that. And I think in tying that together, in your work in menopause, it's a trajectory of aging over your life course. And the experience of chronic structural racism is a chronic stressor that actually promotes aging and increases risk of diabetes, cancer, heart disease. And with cancer, where I'm working at the intersection with cancer, then cancer and cancer treatments will further accelerate your aging. But it isn't about necessarily getting access, having coverage. There are absolute links to structural racism and the impact on individuals' immune systems and markers of aging that are causing many of these things that we're seeing. And we're trying more now. Our goal in our Cancer and Aging Institute is to use the secrets of aging to be able to find leverage points to increase cancer health equity for women in particular. So I think it's what you said is really critical.
To compound this, you go even a level higher. Women, in general, have less, are treated differently and inequitable. And then you add on that minority women. So it's,
Yeah. And
it's
then
even more
you take an older minority women. There are
Yeah.
many ageist biases in addition.
Right.
I used to call that cancer triple jeopardy. And it is that when I was delivering care in this clinic with the stirrups, I'm caring for older women who would say, "Why do you even care?" You know, I'd say, "Okay, we're going to do your breast exam and your Pap smear." And this woman looked at me and said, "Why do you even care about me? I'm old." And I started out really with trying to. I went back and did geriatrics training and tried to address the ageist biases as well that exist.
And I would find sometimes some of the clinicians would tell them, well, you don't need to get these exams because you're old. And it's not true. It's like, I jokingly say, you check your breast when you get your light bill, you check it every time. And for your birthday present, come in and get your Pap smear. That's the month of your birthday. So
and your mammogram too.
And Pap smear and mammogram kind of go together. So yeah. So yeah.
And I think it's important to note that this type of treatment is going on beyond just women's health concerns. When people have chronic diseases, they're also being ignored. And so it goes beyond just, endometriosis, PCOS being ignored in maternal health. It's when people have, diabetes, other chronic diseases, heart issues, they're still not being treated correctly. They're still not giving the pain medication because they don't believe them. We had one of our associates has, a chronic spine condition, and she was in the office telling them, how difficult this was for her. And they said, it's all in your head, as she passed out onto the floor. And then when she woke up, they said, nothing's wrong with you. But yet she's on the floor laid out, and clearly there was something wrong with her. So for a medical provider to get away with that is just really concerning and
not acceptable. Certainly not ethical. When you were talking about the sugar and the sodium, I was thinking about the NCDs, what we call the non-communicable diseases, and that has been elevated at the World Health Organization to a major issue around the world. But when we first started with COVID, this was really highlighted tremendously because we saw African Americans dying at a higher rate and faster rate. And we knew that COVID would affect people who were vulnerable at the time, but we were thinking things like cancer or debilitating disease. We weren't thinking about high blood pressure, diabetes, irregular heartbeats. And these are the things that we were seeing in our community more, and people didn't even know they had them. And so they were being affected more. And that's what we see now, all of these things that are there that we need to address and make sure that every clinician knows that. And I've really worked really hard to get these kind of questions, these kind of things on the licensing exams, on the boards of the medical boards, to make sure that they start to understand those differences, because schools tend to teach to get good grades, to get good outcomes. And so if you got to pass your boards and having these questions there, they're likely more to teach them.
One of the things, though, that's very concerning, say, in cancer clinical trials, development of new drugs and new technologies, radiotherapies, anything else, is that having multiple comorbidities, all of these other diseases, are generally exclusion criteria because you want to show an effect and you want it to be as uncomplicated. I don't know what rationale you could have when most people of all races, particularly older individuals, have all of these diseases, but they have historically been exclusion from
Right.
clinical trials of new cancer drugs, treatments, and I'm sure in other cardiovascular, other diseases as well. And that's got to end, because then
American Heart Association has a campaign around including minorities and particularly women and minorities into research trials and clinical trials more so. And I can't overemphasize how much disparity there is there in those trials.
oh, it's enormous, and when you add the exclusion of the chronic disease burden, you just exacerbate it. I think it's across the board, and I'm hopeful the new director of the National Cancer Institute at the NIH is a woman who has been running clinical trials groups and is interested in making changes in how clinical trials are done. And I think the FDA has been recently more interested in these issues as well, and I think it's really important.
And Jeannie, you're looking for funding for a grant to train underrepresented scientists to study intersectionality of aging, cancer, and disparities, which is something that you've also been doing for versions of that for your whole career.
Yes, it's very, very difficult. The research funding devoted to women's health probably meets or may not be too far off what Maria quoted for investments in general. And the funding in aging, cancer, and disparities is, very, very little. And it's not always an institutional priority at the National Institutes of Health. And they have enough money right now to fund about 5% of the grants that they get, maybe 7 if you're lucky in a given year. So it's very, very difficult to get funded to do this work, and we increasingly need to think of other models as researchers in terms of raising capital to fund the research. It's a huge research gap.
And I wanted to address something that Lori Ramos said on the chat. It's not only that people of color are being excluded, is that they don't want to opt in. They understand what happened in Tuskegee. They understand what happened in their own neighborhoods. And so for them they have a distrust of the medical system, as they should, because we had somebody in our family, these people came, they took the kid from the home. He was 12 years old. They took him. 3 weeks later, they came back, his body was mangled, and he never talked again. So if that's what they're seeing and that's what they're referencing for clinical trials, why would they want to participate, right? They don't necessarily care about the future of healthcare. They want to make sure that they're healthy and that their families are healthy, and participating in some of these clinical trials have outcomes that could be scary or that they've seen to be scary. And so a lot of times they're opting not to participate because some of the times these clinical trials aren't safe. And so I think that's a huge barrier and hurdle that we have to face as we're trying to get more people into these clinical trial programs.
Yes, I agree. And I would say Regina can speak to it's about the communication and trust and overcoming medical mistrust and doctors talking to patients. When people understand and trust, they do agree to clinical trials. And it's, I think, a huge gap when they're not being offered, because people will assume someone doesn't want it for the reasons you're cited. And that's not always the case. Regina, did you have?
Yeah, that's correct. There's been a lot of effort around that. The NIH has a whole campaign called All of Us, trying to encourage everyone to get involved, and that has its challenges as well. But you're right in that there's lots of reasons to mistrust, and I have my own personal experiences with it, but we can't let it hold us back. Everyone brings up the Tuskegee experiment. Well, my stepmother, her father was one of the subjects in Tuskegee experiment. But if you talk to the families of those men, they understand now how important it is that we don't hold that back from us benefiting from clinical trials. We don't want to let bad things happen to our communities. We don't want to allow them. We put in place as many of the protections as we can. We have the IRBs and all of these things, but we all have to stay vigilant. And I remember when I was in office, President Obama made this commitment not to ever let that happen again. And I certainly, the United States Public Health Service, Tuskegee experiments were performed by them. I ran the Public Health Service. We made sure we put in place that that would never happen within the United States Public Health Service. So there are things there, but we have to make sure they don't. We stay on vigilant, but we also need to benefit from our contributions, that we are included. It's like the census, we have to be counted. We have to have a voice, and this is a place that we have a voice in healthcare.
Part of having that voice, developing that voice, is also having people like you, Regina, in these major national leadership roles. And your role is a very publicly visible one, and you also were very public about getting vaccinated early to try and engender trust where the distrust has been earned over hundreds of years at this point in this country. Do you, and there's a tie-in to Jeannie and some national leadership roles that she has had, which I'll come back to, but I want to hear whether you have hope for, because Torin asked us to talk about the difference between the public health and private health, and we have two public health experts on the line here.
So let me answer your first one, because they're two different things, but regarding vaccines, particularly when COVID, and right now we're dealing with monkeypox and vaccines there too. They're different, because with monkeypox, while it's painful, it's very painful, and we need to contain it. People aren't dying right like they were. In COVID, they were dying really fast. And so it was really important that once we got a vaccine that we could trust. I mean, I was going to make sure that it was safe before I ever said, take this vaccine. With Tuskegee, we weren't allowed to get treatment. The treatment wasn't provided. I mean, they knew the treatment was there for syphilis, but they didn't treat them. Here we had an opportunity to be treated. So we were holding ourselves back from being treated, which was totally the opposite. So it was really important that we access the care that was available for us during COVID and with the vaccines. And there's this whole philosophy around how we help the public. Public health and what was the other one you called it? Just general health? Private health. Well, public health is different from private health. Some people think of it as public hospitals. Public hospitals are part of the public health, but public health is the health of the entire public. So clean water, when you turn on your faucet, you don't have to worry or boil your water. When you breathe the air, it should be clean. When you have a disease and we want to contain it so that it doesn't spread and it spreads to everyone else. That's what we consider with public health. And public health, certain things in public health basically are there. We tell you to wash your hands. We're telling you that for a reason. You don't have cholera outbreaks. You don't have sanitation things. Those are public health issues. We've gotten it confused with public paying for healthcare. And public paying for healthcare is not exactly the same thing as public health. They kind of go together, but they're a little bit different.
And I want to ask Jeannie a question, and then I want to have Maria talk about contraceptive deserts in Ghana and work that has been done there. One thing that maybe some of our attendees today don't know about Professor Mandelblatt is that the work that she did in the hospital with the stirrups led to amazing findings on pap smears, and then in what I think was a flash of brilliance in the 80s, Jeannie called in a medical or a health economist to do analysis and then lobbied to get pap smears covered by the government so that probably millions and millions of women have since 1989, 90, 91 have benefited tremendously by that coverage and by a more public rollout of screening. It was the first cancer screening that was in fact covered. And that was an enormous breakthrough in and of itself. But then Jeannie also led a national task force set up by the government on breast cancer and mammograms, and has been widely cited in the popular press and the scientific press for the work that she's done on developing those guidelines. So with more than 300 peer-reviewed academic articles and the Singular Lifetime Achievement Award from the American Society of Preventive Oncologists 2 years ago. And from your seat in an endowed chair at Georgetown Medical School, where you've taught for many years and trained and researched for many years, are we actually set up to succeed in tackling COVID and monkeypox, or are you seeing things that made it look like the early days of the AIDS epidemic, where you were also providing frontline medical services?
Well, there are a lot of, let me unpack that a little bit to address it. One of the things about the pap smear screening we did for the then Office of Technology Assessment that led to Medicare coverage is we showed it was a very inexpensive technology at the time, under $5,000 per year of life saved which is very cheap. Right now, we're paying for things and doing things that are about 150,000 per year of life saved, to put it in context. But importantly, we found that Black older women have substantially higher rates of cervical cancer and lower historical access, and offering pap smear screening to those women via Medicare actually saved dollars and lives. And we went on in some of this recent, what I call the mammography wars. I've led a group called CISNET from the National Cancer Institute that has done modeling for the U.S. Preventive Services Task Force and the task force recommendations have been tied to insurance coverage under Obamacare. We looked at mammography guidelines, and recently, working with one of my colleagues, Christina Chapman, we looked at whether the U.S. Preventive Services Task Force guidelines for the overall population, where they have been recommending every other year screening for women from 50 to 74, were those the right guidelines for Black women? And Dr. Chapman showed that if you want to reduce mortality disparities and achieve equity in the gains from mammography screening relative to any harms, the strategies you would pick would be starting every other year at either 40 or 45 among Black women. And that article, which was in the Annals of Internal Medicine, had an editorial by an older white man from Harvard saying that race-based guidelines were uniformly bad. And I think that they are in some instances, and they're not in others. And that this issue, to me, the response was racist in a sense to what we were doing, and that those issues are very pervasive in how we address public health. And I think that groups like the task force and others are beginning to think about maybe our goal is achieving health equity, and we need to look at our guidelines in those terms. But in the second part of your question, which was about monkeypox and COVID, I think the monkeypox is really distressing because it's been getting press as a disease of gay men, as was AIDS. It's a disease of having sex or any physical contact. And the fact that it's being in the media, it's being covered as a disease of gay men is so stigmatizing and to me, counterproductive in the kinds of public health messages that Regina is talking about. It's just wrong. And like, oh, it's over there, it's them, and they have this thing. And I think that those types, it's a very stigmatizing way of approaching disease.
Yeah, and I think that we would have conquered COVID, and there were questions about red states and science denying in the chat. We would have conquered COVID and had really good reporting on it if if Fox News had reported that COVID is much higher occurring in people with amazing sexual prowess and phenomenal intellectual capabilities.
And older white men.
Exactly. And Maria, first of all, thank you for mentioning endometriosis. I'm actually wearing my Screw Endo shirt today. I have a family member with endo who made and sells these. And endometriosis is a good example of something that we don't talk about because men often control the conversation. Can you talk about your investment in Zipline and how we capitalize, like where's the venture opportunity for this stuff? And I know you're going to have to leave us a little early, but.
Yep. So we invested in what you wouldn't think typically was a women's health company, a company called Zipline, which delivers medical equipment and life-saving vaccines by drone. And so, even though it's based in San Francisco, they started out in Rwanda and Ghana testing their drone systems. And when they came to us for an investment, I said, well, this doesn't really look like a women's health company, but our company is focused on investing in companies that provide access, care, and better outcomes. And so they said, this is an access play, but also we've created better outcomes because we saved the lives of 15,000 women who were bleeding out during childbirth because in order to get them the blood that they needed to these remote locations in Ghana and Rwanda, it could take 4 hours by car, but by drone, they could get it there within 20 minutes and we're able to save lives. And so for us, like anybody that's saving the lives of women is good in our book. And so we made an investment with them and are so glad we did because they have a really authentic commitment to women's health care. And so in 2021, we put together a program because they were going to a new headquarters. And one of the other things I like is that they don't go into these African communities and exploit them. They tried to add value to the communities which they're setting up. They hire locally and they want to help the community locally. And so one of the things that they realized was that the women in the town in Ghana did not have access to menstrual products. And so it was National Menstrual Day, and they had reached out to me to see if we wanted to participate in helping source tampons and pads. And these were, menstrual products. But I said, this is great, but after 1 month, these are gone. And then they're back to the same situation they were before. And we had invested in a company that had sustainable period underwear, which I'm sitting in the warehouse right now today. And I said, this is a better solution for them because they can continue to wash and wear this instead of just, having menstrual products for 2 months. And so I flew over to Ghana and partnered with Zipline. We were able to drop over 2,000 pairs of period underwear by drone to remote locations and period deserts in both Rwanda and Ghana. And we had a half-a-day program teaching the girls how to use this period underwear and about menstrual health. And so, by the end, we kind of videotaped them. We're like, do you know how to use it? And they said, yes, we have our periods. We go to the river, we wash it, we lay it in the sun, we turn it over so it doesn't get mold. And it was such a great experience. And when we sat down with the chiefs of the villages, there was 10 villages that participated in the program. They said, this is great. Our girls can stay in school because a lot of times at the age of 12 or 14, they dropped out of school. They would become, child brides, and they weren't able to be productive earners or members of the society. And they said, by allowing them to stay in school, you've effectively been able to change the economy of our entire village because now they can learn how to read, they can learn how to do math, they can maybe go on to school, or they can start businesses and be productive workers in our society. And they said, there's only one problem. And I said, what's that? And they said, what about their moms? And I'm just like, yeah, they're like, we need to get them to stay at work too. And so, this is the type of programming we do, and we're not an impact fund. We're a returns first fund. But by partnering two of our portfolio together, we can create some massive impact, and also great financial returns. But that was just something that was really amazing to me. And this isn't only happening in rural communities in Africa. This is happening right in our home state of the USA. This is happening in Kentucky. This is happening in New Jersey. We are doing these same types of things. There's period deserts all over the US. And so we can make change right here at home.
That's wonderful. And the same goes for fibroids and the white dress societies, which is girls or women who can't wear white dresses because they never know when their period's going to be on. So it is very real right here in the US, as you said. So that's amazing.
And Regina, you've got an investment in, or you're on the board of Norex. Do you want to talk about that and how that ties in here?
Well, we started because after a few years ago, when the Affordable Care Act was being attacked and trying to get rid of it, women didn't have access to birth control. And so we wanted to start a affordable way for women to have access to birth control based on on the internet. So it's basically an internet, which has now come to be telemedicine platform, so that you didn't have to pay for a password. You didn't have to do all of these. It would be much more affordable, and to have their birth control available to them. And that's how Nurex got started. And it was birth control pills and PrEP, because we said the same problems with HIV PrEP. And so making it affordable was a challenge. And it's now been, a women's health kind of platform now.
And because of Nurex, a lot of other interests have come into the market because they realized this lack of access. And so we've invested in a company called 28 Health, who has a platform as well that are serving underserved communities and also Medicaid communities, as well as, as Hispanic communities. And so they have Hispanic doctors, Hispanic, customer service, because we want to make sure that we can serve all types in the communities. And we realized that a lot of these communities, the users were Spanish. And so it made sense to talk to them in their language and to understand their concerns in the way that they can communicate best with us. And I feel like a lot of commercial platforms forget about this part. Not everybody's living in San Francisco and New York. Not everybody, has Wi-Fi and access. And so we're really trying to focus on companies that are thinking about how to serve this kind of overlooked and underserved segment of the population. And so, but it's great, that people like Nurex kind of paved the way, and then the people like 28 Health are kind of taking the next steps to push that forward.
And
But
it's much easier.
Yeah,
I know you have to leave
because we're doing more great period underwear sustainability. And so I have to go, but this was such a great conversation, and I'm leaving you in good hands with, Dr. Benjamin and Dr. Mendel-Blatt. So thank you all.
Thank you.
Thanks for everything you're doing.
Great story. I've been really quiet so far because I'm so honored to be a part of this conversation, and I usually find myself with a lot to say, but I'm learning so much. It's straight. And for those I haven't met yet, I'm Meredith Bouchard. I'm a partner at Lowenstein as well. It strikes me that there are a couple pieces to the problem. I mean, it's a very large and depressing problem, but there's coverage, and then there's access, and then there's education, and we have to overcome all three in a lot of different areas. But getting that Medicare and Medicaid coverage, and Jeannie, that story about you and bringing in a health economist to think differently about pap smears. Are there other areas that you see where we need to get over the coverage hurdle in order to get to the access and education piece for public health?
So one of the things we did with Nurex was that, again, when we first started, we didn't do Medicaid because Medicaid patients were covered. Birth control was covered on Medicaid. But it was the people who didn't have Medicaid or any other kind of coverage that was having problems. And in a place like Alabama, it's if you make over $200 a month, you make too much to qualify for Medicaid. So it was the very poor, but they were oftentimes working. And so what I'm getting at is when you start looking at some of your platforms and things, there's an entire group out there who doesn't have coverage, but they're working. And if you can bring those prices down, we could get to them. And when you look at everyone wants to scale, there are high numbers there. There are large numbers of people in that range that are, I call, self-insured. And if you could find a way to make things affordable for them, it would be a tremendous improvement in healthcare delivery.
I think that makes a lot of sense. I also think that we need just fundamentally different ways of looking at our problems. I think the example of Maria trying to promote women's health and menstrual health, coming together with a company that does drones, that is
That was
really creative. And in our research, we try to work across disciplines. I now know I was actually invited to be on a panel on the use of cost effectiveness in health and medicine based on that conversation, work with a health economist. But I've learned that the ways of approaching structural racism, health problems, take looking at it from lots of levels, from what's happening at a cellular level on up through the policy levels, and be able to work with people who speak a different language or do something different than you to see how you can come together and have an insight you would not have otherwise have had yourself. And so I find that the words education, access, they make people think in one way that we've been thinking. And so I don't know that it's not necessarily the terms that have to change, but I think we have the opportunity, and people who are creating products and funding products have that opportunity to really think about creative solutions. I mean, we may be looking to find solutions to understand how aging, we can use the secrets of aging to improve cancer health equity, and maybe we'll find something that'll help slow aging along the way. And we need to look at creative ways to do that, but much more broadly in the public health and broader policy arena that Dr. Benjamin is talking about, it's about a fundamentally different approach to the same problems.
You know, I agree with that, and health in general is very personal for everyone, and oftentimes you don't necessarily you don't know the answers to things. So using technology, giving information, having that at, at at your phone to be able to find your own answers, or having someone help you get those. And if there's a way a company could have reliable information that's there, and people can kind of take control of their own health, because that's what we want you to do, is you need to be in control of your own health, which we haven't done in our healthcare system very well, you know. And so that in itself is a new way of looking at things, and giving people the tools to handle their own healthcare. So
yes, we have so much technological capacity that has not been applied and deployed in the way you're talking about. It's just scratching the surface now of apps that help you track your weight, your blood pressure, help you stop smoking, and there's so much more that can be done. And that paternalistic history in the healthcare field is, I hope, gradually changing as the face of healthcare changes, but it's really does not empower people to take control of their own health.
You know, Alex has a question on here about the challenges in our culture, divided into three parts: access to education, healthcare, and capital. Well, you know, all through my career, the media would ask questions, and they'll say, like, what do you think is the biggest healthcare problem is? What do you think, you know, answer to healthcare? I always believe it's education, because if you can get people educated enough, you can explain, they can use the education to improve their healthcare. But we do have that challenge to education at all levels, and that's a challenge that it's not just healthcare. We also have studies that show that just by getting a high school diploma, you've increased your longevity and your what is it, your life expectancy rate, just by getting a high school diploma with nothing different. So education is so important. I just wanted to agree with Alex. So.
Meredith, did you want to continue?
Yeah, I mean, that resonates with me. And I think there are a lot of avenues for education, and certainly a high school diploma helps a lot, but there's a lot being legislated in various states about what can and cannot be taught in high school relating to health, menstrual care, contraception, which leaves a rather large gap and a challenge and perhaps an opportunity as well for innovators. I don't know if you have thoughts on that one.
Well, I agree. And again, healthcare is personal. There's some basic things. I mean, we don't teach health in school. I mean, that was one of the things in Surgeon General is when we talked about obesity and other things. Used to, I'm older, much older. We had health in PE. You at least get health class at one of your PE classes throughout your school. Now we don't even teach health in school. So learning the basics is really important. But with the political climate now, I don't know if we'll get that. And so is there any way that a parent or one could go and have some reliable source of information to be able to help them teach their kids, basics?
Yeah, and I think some schools are teaching health, others are not. It's different state by state. I know in my public school district in New York, we generally do some health, though that's one of the things that we lost during the pandemic. Health stopped being taught for a couple of years. So my 12-year-old didn't have the elementary course on menstruation that most 5th grade classes get. And I can do that with her, but for a lot of families, it doesn't work the same way. And there really are gaps now to be filled. I think there are parents looking for good solutions, but there are also a lot of parents who aren't, right? And a generation that's going to come with some gaps in their education as previous generations have, which is something we'll have to contend with.
And with those gaps, the education issue, Jeannie, when you entered medical school, you and I talked a while back about the percent of the entering class in medical school nationally, the year that you entered, that was female. Can you talk?
4%. And it's now about 50%. And so that's been a really encouraging thing in terms of the face of medical care and women's health, having more women. Where we're really, I think, more struggling is we have few underrepresented minorities in medical schools and in the sciences. And we have, in this climate that's very anti-science at all levels, this current, I just don't get it as a scientist, but that we could be so anti-science in facts. We don't have the kind of training and support that we need for women of color to be advancing in science, technology, medicine, and that's a real gap. It's a gap in our cancer and aging. It's a gap that's under addressed in most systems.
We're trying to improve the pipeline for minorities. While 40% of the population is minority, and in some places even higher, less than 7% of the physicians are minority. And similar for nursing and pharmacy and other health careers. That's the same percentage as during the Flexner report of 1910. The percentage hasn't changed. We really do need to improve that pipeline in science and math. And in some places, particularly the government, they don't consider medicine as part of STEM. So I want to make sure that it's science as well as medicine that's being taught.
I always think that medicine is science.
I do too. They just don't include it.
Yeah, and it's a gap. I'm not sure how companies and technology can address that gap, but it's a gap in the NIH funding portfolio across all levels. And I've had a hard time getting funded to train underrepresented minority scientists from early pre-doctoral with stages, bridges to the doctorate programs in cancer and aging. And, you know, it's a uniformly, the numbers of programs that exist across the board are just too few. And I think that we're not going to get to health equity and thinking about the solutions in a way that reflects people's lives without that.
But when it comes to medicine,
progress for women, but not otherwise.
but when it comes to medicine, we need to get kids before the fourth grade, fifth grade, because if they don't take algebra, they're going to go down a different path. And it's very hard to come back. And so getting those young careers, at least on a math, to take math, really makes a big difference in their long-term career. So I always say, if you see a kid, just encourage them, you know, just ask them, why don't you want to go in, you know, not, or suggest they might want to go into one of the sciences or technology or engineering or something, because nobody may have ever told them, you know.
I'm fairly active in some organizations around getting girls into STEM, and there are lots of opportunities to get involved. They're pretty terrific. So talking about, you know, more women in medical school now, that's a good thing. Not nearly enough men or women who are diverse, and it kind of echoes what's happening in law schools, right? We have now 50% female law school, but we're not seeing women well represented in different areas of legal practice. Are you seeing something similar in medicine, or are you seeing women who go to medical school now in all areas of medicine, practitioners, researchers, and really rising through the ranks to leadership? Certainly we don't have enough representation in leadership ranks, but now something similar is going on there too.
It's very similar to venture.
Yeah, women in leadership positions in medicine, in medical school, deans, and cancer center directors, very, very few, very disproportionate to the number of women in medicine today.
And especially in the leadership positions, you know,
Leadership position. Yes, exactly.
And Jeannie, your first, I don't know if it's your first 100 peer-reviewed academic articles, but it's some very significant number of the body of work that you've produced. You are listed as either J. Mandelblatt or J.S. Mandelblatt.
Yes, I started from the beginning of my career. I recognized that if I signed my name Jeannie Mandelblatt, I wouldn't necessarily get replies to applications, good reviews, or anything else. And I was trying to be gender neutral then in the and now when I'm still doing that in our promotion and tenure committees. It's still amazing the implicit bias and how hard it is for me to get my colleagues to use gender neutral pronouns in referring to a candidate, and that those biases still exist. I do go by Jeannie at this point, but I didn't for a very long time.
You also felt like your academic work would be taken less seriously?
Yes. Oh, not reviewed as well, not taken as seriously. I wouldn't be taken as seriously. And even as a tenured professor, when I'm in a room with my male colleagues, I'm not taken as seriously, and I'm not given the weight for my achievements that the men are.
Can you, speaking of your achievements, can you talk about, you've been knitting this whole time, and I know that you are a relentless cancer battler and also relentless at knitting, but can you talk a little bit about what you do with all of that knitting?
Yes, I have two charities that I have founded. One is called Knit One, Cure One. We were talking about at the beginning of the call, and I love to knit. I'm passionate about color, fiber, and texture, and it's a wonderful thing to do during calls. And all the money we sell the products and donate 100% towards breast cancer community groups and breast cancer research. And I also founded a breast cancer walk because I believe, in doing the research, but being on the ground and walking warriors battling breast cancer. www.bbc.org is our local walk. And we donate. This year, one of our beneficiaries is an organization called 4-3 Sisters, started by a firefighter who lost 3 sisters to BRCA, 1 or 2 mutations, and they take a pink fire truck through all of our DC communities, providing help, housing, meals, mammograms, access to care, and they've been one of our beneficiaries.
That's wonderful. We'll have to connect you with Girl Track. So Girl Track is a organization. When I was Surgeon General, I had these walks with the Surgeon General and walking for health and that sort of thing. And there were these 2 young ladies who would come to the walks, and they started an organization, a nonprofit called Girl Trek. And Girl Trek now has over 1 million members, and it's African-American women who are walking for health. It said, we walked for freedom. We walked during the civil rights. We walked Sojourner Truth. We walked for freedom. Now we need to walk for our health. And so it's all about health awareness, socialization, and it's really been a successful organization called Girl Trek. And we walk on Saturdays, walk virtually. So, and I think the 2 organizations could probably team up and do some good things.
Yes.
I would love to see some more partnering opportunities out of this. And I noticed that the founder of Berry Health is on the line, and I don't know if he is sitting in Ghana today. And that's a company that I don't know if I'm allowed to say that I invested as an angel investor in the company, and then I made an intro to Regina because we have partnered on a number of investments, both through First Close Partners, which I'd love for us to talk about, but also in some other angel and venture investments prior to First Close being started. And I get this call back from Regina saying, thank you so much for making that intro. Love the founder, see why you like the company. Love that you made an investment. By the way, I took half your allocation. And it is an honor to be cut back by Regina, and it is not the first time that she has done that to us, which is great. But
so tell them what Berry Health does. And
yes, you should do that, or the founder can unmute himself and do that.
That would be better.
Great. So great to meet everyone, and this has just been an amazing panel. And so many of the things that have been said today have been poignant. But essentially, what we do is we're direct to consumer telemedicine company. So we offer remote diagnosis, treatment, and digital pharmacy delivery for chronic conditions. But we're focusing on stigmatized conditions. So, to cover some of the things that Regina said about problems in coverage, access, and education, this is exactly what we're covering. And some of the things that Maria talked about in terms of like contraceptive deserts in Ghana and other parts of Africa, but also the world, as Ed pointed out. These are not things that are unique to the African continent. Certainly they're happening in the States, they're happening in the UK and other parts of the world as well. So we're in here trying to democratize access, giving women and men access to be able to better take care of their sexual health, their mental health, their dermatology, and pretty much using the smartphones as a medium to be able to give them the tools to put healthcare in their own hands. So that's what we do in a nutshell.
And are you still in stealth mode, notwithstanding what you just described?
Yes, but we'll be coming out of that soon. Where I'll be liaising with you and Regina really soon. We're about to start a closed beta at the end of the month, and we'll be coming out of stealth pretty soon in the next coming months. So more to come.
Thank you so much for sharing that, and also for for letting me in, although I don't know if I was just an excuse to get to Regina, but I'll take it. however it comes.
No. We wanted both of you.
Right. Well, thank you for what you're doing. Look forward to the next big update. So, but it goes to show that the issues that we're talking about on this call are not just the U.S. issues. They're not just in the South where I am, or they're not just in inner cities. They're all over the world. And so, being global, we are a global world. And so, companies or those out there who are interested in startups, it's not limited. So you can find solutions to these problems, and here in the US and internationally.
And how are we doing with diagnosis, detection, screening, and using the digital benefits? One of the criticisms about where venture dollars seem to land, venture dollars land on things that are entertaining, things that are
Nice
getting
and
us,
shiny. If they're nice and shiny, they sound like a new technology, or they're something that's come out of Star Wars or something. Everybody wants to invest in it. But the real change in healthcare is these things we were just talking about: the non-communicable diseases, the diabetes, the hypertension, the obesity, the lifestyle changes, which are very difficult to deal with, because changing your lifestyle and your behavior is hard. So, and that behavior includes clean air, clean water, the things that really impact our overall health. And health doesn't occur just in a doctor's office. It occurs everywhere we are, and everything that we do, our jobs we go to every day. We haven't talked much about behavioral or mental health. All of those are health. And so all of that is what health is. And we may not find one piece of technology or one piece of shiny new technology, or even some scientific discovery to take care of all that. It's going to take it all. And so the more we can take care of the real issues that people deal with every day, the more impact we'll have on health.
And there was a comment, I won't identify the speaker, but it was a reference to a company that received venture dollars, although most of the investors were funds that are underrepresented, owned and operated, and they invested in Medicaid moms. It's a company that serves Medicaid moms, and one of the comments was, how many people in Atherton know personally Medicaid moms? And Atherton is a wealthy suburb in Silicon Valley, and is that is a market opportunity, right? Because the ability to look beyond the narrow set of insights and lived experiences in the majority of the venture community also means that there are value investing opportunities. The flip side is, of course, that we're not putting enough money there. We're not putting enough money into things like the nexus of aging and cancer, which I know is near and dear to your heart, Jeannie. But are we starting to tackle those opportunities, Regina? I know you serve on public boards, you serve on venture-backed boards. Are people starting to put the dollars in the right places?
They're talking about it. At least the awareness is talking more. But in order to truly scale, you're going to have to get to every community, even the ones you're talking about. So I think people understand that that's the only way we'll have to get to the general public, is we're going to have to include these populations that people have ignored. They've gone after the high earners, the wealthy areas, and that's not enough.
And Jeannie, are we at risk of overdoing it with all of the screening and diagnosis, and in particularly where people are affluent and have access to a seemingly endless array of diagnostic tools, what are some of the harms that we are inflicting upon ourselves?
Well, it's who's inflicting the harms from overuse of screening. I think any type of thing that we do, any medical intervention has benefits, harms, costs, impacts on quality of life, and those need to be judged on balance. In the screening arena, there may be women using screening more often than is recommended or more often than they need. And on the other hand, we have women who are not getting access, sufficient access. But when, and what happens with a message about what's called overdiagnosis is that as a harm, excuse me, my son fixed just this moment to call.
So,
But so what I was going to say about the harms is that, you get a screening test done, and I think the cool new technology, and there are a lot of companies investing in earlier diagnosis through blood-based detection of cancer tumor DNA, is you can find some abnormalities, but you don't know if you have a cancer or where it is, and you're going to cause a lot of anxiety. You're going to induce a lot of tests to try to find that. Sometimes you'll find a cancer that might not have ever come about and harmed you in your lifetime. And that needs to be balanced among not getting enough care to detect things and treat things early for many diseases. I talk about cancer because I know that one best at this point. But it does need to be weighed. But what happens is if that message about the harms becomes louder than the message about the benefits, you lose people to getting it, like vaccines, for instance. In the COVID vaccine, the messaging went a bit awry, I think. So I think it's a complex question. I think Regina has something she wants to say about that.
no, I agree with you. And there is technology that's improving about directing care, individualized care and specialty care. And I think that'll take us a long ways into improving things, where it's particularly around cancer. We're seeing some of that. But it's that area, just like you said, when we start to screen, we call them the worried well, that's willing to go out and pay a lot to get all these screenings. And then you find something, and some people in the science community thinks that the screening and all the testing after the screening to show that it was negative can be more harmful. And so there's some sort of not resistance, but caution around that. But on the other hand, there are people who are not getting screened for basic things. I mean, basic preventive health. Those basic screenings that were covered in the Affordable Care Act are being whittled away, and they're not covered anymore. And so, the number one cause of death in the preventable death in the United States is smoking, cigarette smoking. And yet we're not talking about it. We don't treat it, but it's still the number one leading cause of death, preventable death in the country.
Can we talk a little bit about Dobbs? And Meredith, do you want to talk a little bit about the article where you were the lead author on Dobbs in a venture context?
Absolutely. To give the same caveat that you gave at the beginning, this is my personal opinion. This is not anything more than that. I was in a pretty dark place after Dobbs came down, as a lot of my friends and peers were, and had a meaningful conversation with Ed about feeling like I didn't know what to do or how to have impact other than to feel sad. And this, see if I can make you blush, Ed, but this goes to the power of mentorship and sponsorship, right? To have trust in someone to say, I don't know what to do, and have them say to you, I think this is within your wheelhouse. I think you should find your voice here. and let's think about it together. So I'm very grateful for that, Ed. And so Ed and I, along with a number of our colleagues, Alyssa Friedrich, Rossi Terman, and a few others, spent a lot of time talking about what can we do and what does this mean for the companies with which we interact every day. And this does impact venture companies, not only venture companies in the health access space, but all of them, because they all have employees, right? These are human-run businesses, as all businesses are at the end of the day. And it's very sad to me that that conversation about reproductive rights access and health access needs to fall to private employers. It leaves a lot of people out of the conversation who are unemployed. But that's where we stand at the moment, in my view. And so thinking about where are these employees located and what have these companies done, or are they thinking about doing, following some major US corporations in committing to protect and enhance reproductive rights and access for their employees? Are they committing to provide for travel and costs for reproductive care for employees who need to travel in order to get those things? And not just employees, but also dependents of employees, defense costs if a state goes after those employees for aiding and abetting, access to reproductive rights. There's a lot that companies can do. All of those things come with risks. And there are no answers yet because we're still watching enforcement in a number of states to see what's going to come down. And not just enforcement, but we're watching legislation and potential constitutional changes in states like Kansas. So keeping an eye on that, we want to be talking to the companies with which we work about what they can do, what are the risks of doing that. And then when it comes time for major corporate transactions, think a financing round or an M&A exit or an M&A add-on, and it comes time to make representations about compliance with law, right? That's a moment to think about, how do you disclose what you're doing? As a buyer, are you asking a company to represent that they're fully compliant with law? Or are you asking them to represent they're compliant with law, except where compliance with law would diminish reproductive rights and health access, right? Because that's a different standard. And so that's something we're thinking about. We've written a good deal about it. You know, in the M&A context, and I spend a lot of my time selling venture-backed companies, I also have always thought about how are employees going to be treated after a deal, something a lot of founders care deeply about, as they should, as should their venture backers. You know, in addition to being the right thing to do, it goes to your reputation in the market when you find good homes for companies that are exited and keep employees happy. So we overall want to see benefits packages being continued and not made worse after an M&A exit for a venture-backed company. That should also extend to reproductive rights. So important early conversation we're having with potential acquirers is, what's your stance here? What are you going to do for these employees? The board needs to understand before committing to sell to you what this impact is going to be for the people who work here and their dependents. So it's the beginning of a conversation. There's a lot more work to be done here, a lot more conversations to be had as the law and enforcement continues to develop. That's really where I am at the moment in thinking about it. And I'm excited to continue to talk to everyone who's wanted to be a part of this discussion. Excited, not a great word, wish we didn't have to have it, but I think we do.
And we also in the article we covered, and thank you for that, Meredith. We covered, if you are a venture fund, why not put in your term sheet in the section on board of directors a statement that your fund commits that the board members designated by the fund will protect and in fact expand the reproductive rights of team members. The board members designated by your fund will, in fact, protect and expand the equitable health access of your team members. And in the M&A context, we would love to see investment banks say to bidders, we are going to consider and prioritize those buyers that tell us that they will protect and expand equitable access to health and reproductive rights of team members. And we believe, and we make arguments in the article, including citing to the statements put out by the Attorney General of the state of Delaware, which is where almost all of these companies are incorporated. We believe it is consistent with your fiduciary duties. And this goes back to something that Maria Velasaris said about the young girls who now don't have to drop out of school at the age of 12 or 13. If you are forced, if your employees, if your team members are forced to carry a child to term, if they are forced to suffer the medical consequences of the unavailability of D&C after a miscarriage, because a doctor does not know how state law will enforce putting the life of the pregnant person at risk, or the life of the person who miscarried at risk, because these are very difficult legal decisions, then you are materially adversely impacting your ability to attract, retain, protect, get productivity from your employees. So it is very consistent with your fiduciary obligations to protect those reproductive rights and to make that a priority in our view. And we are going to work on a subsequent article about that. And if you think that representations on compliance with law don't apply to you, every form document that is a safe from Y Combinator, if you go to the Y Combinator website, which is where the form of safe is done, and so many seed financings are done using those forms, there's a representation that says the company complies with law in all material respects. That may not be something that you actually can represent, and there are ramifications to that. And why not proactively change it? In the article, we asked Y Combinator to change it and say, except where it adversely impacts the reproductive rights and access to equitable healthcare of our team members.
So are you telling the Y Combinator people not to comply with the law?
I am telling Y Combinator that, and this is, again, this is me personally, this is not any company or organization with which I am affiliated. I am saying that the rep that I think you should care about in that form is, we comply with applicable law in all material respects, except to the extent that doing so would impair the access to equitable healthcare of our team members,
So,
and their reproductive rights.
so playing devil's advocate, you're saying, okay, comply with the law except when you don't like it.
Sure, absolutely. Comply with the law except where it is, except where there has been, and I'll use the word miscarriage. I know it has multiple meanings here, except where there has been a gross miscarriage of justice. So I would, people talk about, we can have conversation. The history of the way we react to unjust laws is that there has to be civil disobedience. That civil disobedience comes with a cost. And
That's
when you
what I
have
was
a
going to say.
state,
Why don't we tell people to change the law?
we are. I mean, when you have a statement from the Attorney General of the state of Delaware saying, I will not enforce, if this is the law, I'm out, I'm not enforcing, and I will tell our people not to enforce. When you have that kind of statement. So, and just to continue to play devil's advocate, Admiral Benjamin, when we talk about the cannabis industry, cannabis is not legal as a federal matter, and there are tax laws, including 280E, that deal with some of the repercussions, right? There are state laws that say cannabis is okay under these circumstances. So the venture capital industry, angel investors, founders, startup executives, the accountants who advise people on what to do with their stock options in these companies, the law firms that lawyer these deals, the insurance companies that underwrite these deals, the landlords that lease space, they're all complicit in knowingly not complying with federal law to an extent, right? In this instance, you know, I think that there are a number of instances where it is a rational and just thing to do, and you know, I do think that there is compliance with law, right? We've all crossed the street against the light at one time in our lives. That is certainly intentional non-compliance with law. There are degrees and there are bases upon which we make these decisions.
So
I-
if you and Meredith are the lawyers, so I don't, want to say that's my expertise, but I want to just kind of mention what I thought about Dobbs when it happened. We were all disappointed, but I started out this conversation talking about the code of ethics and seizure and those things, and the patient-physician relationship that we hold sacred. And we do as physicians. What Dobbs does is it brings the legal community into the exam room. It should be that relationship between that woman and her doctor or her clinician. And I shouldn't have to, as a doctor, shouldn't have to be worried whether I'm going to go to jail because I did what was best for her. If I followed my own code of ethics, am I going to be criminalized for following that code of ethics? That's what this first thing that I felt when I got it, and that is a challenge. The other part is that there's always so many different sides to everything, and people are in different places, and there's a spectrum of where people are. I will say I believe that a woman has a right to make her decisions, to choose. And so, but I'm not pro-abortion. I'm not going to go advocating you go have an abortion, but my personal feelings, I don't put in the exam room with that patient. I don't. You can be for choice, but you don't have to be pro-abortion. I mean, it's a subtlety, but they're two different things. Now, I would respect your meaning a patient's decision, or if that's what she wants, I will respect it, but I don't have to put my feelings onto her. And so what we're seeing is that we have all these different points of view, and how do we allow people to be for reproductive rights and not necessarily go against some of their other, personal beliefs? Because you can do both. I think you might not agree with me.
Meredith, I don't know, or Jeannie, if you want to jump in first.
It just reminds me, though, I think that as a physician, what Dr. Benjamin says resonates very much. And there's no business of lawmakers or Supreme Court in that. But
We just lost your sound.
can you hear me now?
Yeah.
I started medical school in 1972, and Roe became law in that period. And after 4 years of college of protesting the war in Vietnam and being involved in draft card burning and earlier in some civil rights marches. And I do believe a vocal protest and getting people out to vote as a way of vocal protest is really, really critical. I can't comment on legality or illegality or how to use the types of things you're talking about. I do believe we cannot remain silent.
I agree with that, particularly around our rights and our being out there protesting, doing the things, raising our voices and making sure we're heard. That's really, really important. And somehow the dialogue gets polarized when there are so many people. I mean, I hope there are people who believe in rights and women's rights.
Women's rights, civil rights, all of I feel like our freedom of expression, so many rights are under attack right
Yeah,
now.
and just to clarify one thing, this legislation, and as a lawyer, I do not want to be in the exam room. And these are the rights of people who are or can become pregnant. It is not just a women's issue, it's a folks issue. And clearly, Clarence Thomas put contraception in the crosshairs, and then days later, we had 96% of elected Republican federal, elected Republicans in Congress voting against enshrining the right to contraception in law. So these are very broad rights, but also if you experience an ectopic pregnancy, if you need a DNC, if you have potentially life-threatening risks associated with pregnancy, if you have rheumatoid arthritis, lupus, inflammatory bowel disease, and many other things, if you have certain types of cancer that require testing that is consistent with abortion care, all of those things are going to be potentially problematic. They are going to lead to potential enforcement against medical professionals who attend to your situation. And we are going to have to do battle with pharmacists who feel that they have religious beliefs that prohibit them from dispensing the healthcare to which you are entitled. And those kinds of things are, I think, why this is such a deeply problematic outcome, in addition to the fact that abortion care should be available. And we should not have lawyers arguing who gets to, which doctor gets to decide on whether the doctor made the wrong decision about, what constituted a threat and how severe the threat must be to the life of the person who is or was pregnant. Meredith, it looked like you were about to jump in.
Yeah, that's really well said. And I think this really diminishes the ability of doctors to provide quality care. But to me, it's really about the patients, about the people who are or can become pregnant and their own bodily autonomy. And Regina, I'm with you. Abortion should be safe, legal, and rare. And let's get on the education and the contraception. So, but it also is a fact of life that it needs to be available. And no one has to have one, no one has to perform one, but for those who are going to need that procedure, blocking access is a real problem. And so back to the legalese side of it, the idea for me behind pushing the Y Combinators of the world and the buyers and investors of the world who are not using the SAFE documents to lead with a form that says, you, company we're investing in, or company we're buying, are compliant with law, except where it would impede the reproductive rights of your employees, is really a level setting of expectations and a unified voice across the venture space saying, whatever you're doing, company we're going to invest in, that protects reproductive rights, we want you to do that. We don't want you to start telling us, listing all the ways in which you're flouting the laws in order to help people have access to reproductive rights. Because you could do a deal, right? You're a company that protects reproductive rights, an investor gives you a form SAFE, you can disclose against that representation. You can say, okay, here's our exception, here's what it is. But for a buyer or investor to come in and say, here's our baseline expectation of where we want to invest, protect reproductive rights, we're good with it. We actually want you to do it, is a very different message. And if we could create a uniform voice there, I think that's pretty powerful.
Regina, I know that you have to take off. I don't know if you wanted to give us a parting shot before you actually go and work on health equity as you chair a meeting.
I forgot, I got caught up in this, but I was thinking, as Meredith was talking, when I'm in the exam room, if I see a person come in the ER, for example, with an ectopic, am I supposed to sit there and wait until they start to bleed out? And hopefully they'll get back to the hospital in time. I mean, it's just, I'm supposed to watch not only the fetus die, but also the mother may die. I mean, these are kind of issues that are in my opinion, they're not ethical. They're just, they're wrong. So that's kind of what you were saying, Meredith, that's what I was thinking as you were saying. But this has been wonderful. I do hate that I have to jump off, and I'm sure others do as well. But thank you again for having me. And Jeannie, it's been great.
And thank you, Regina. I want to just share one personal thing as we say goodbye to Regina. So I have admired Jeannie tremendously, knowing very little about her professional accomplishments for decades. And I wrote something about 10 or 11 years ago, which I just republished on Medium last night without really editing it. So it's not my best work. But I know Jeannie because in the early to mid 1960s, when my older sister, who has since passed away, was born, my family was economically fragile. We were poor, and my sister was born with very severe disabilities. And my parents did not know where to turn. And my mother posted something in the local newspaper and put something in the local schools asking for volunteers to help pattern my sister so that she could learn to create some functionality in her lower body. And more than 200 people volunteered. A number of those people remained until the end of my mother's life at the end of last year. Sorry, at the end of remained close to our family and were her best friends. One of those people was a 14-year-old candy striper named Jeannie Mandelblatt, who became a part of our family, who never left our family, and who has been an older sister to me, and someone who has just constantly throughout life made the right decisions, made tough decisions, and lived with remarkable integrity. And knowing that she herself did not have money, could not afford college, worked at a car dealership full-time during college, in fact, and still wanted to volunteer as a 14, 15, 16-year-old to work with a disabled toddler, and to see what she has become and the impact she's had on, I don't know how many American women have pap smears in the last 40 years because of 30 years because of Jeannie, and the mammogram standards because of Jeannie. But I just wanted to, in front of whoever's left, say, Jeannie, thank you so much for everything and for a lifetime of good that you have led with. So with that, thank you on behalf of Lowenstein Sandler for coming to this. That I can say on behalf of Lowenstein Sandler. The other stuff about how pro-abortion I am has nothing to do with Lowenstein Sandler. But thank you all for being here and for being part of this and for talking about creating more access, more equitable access, more inclusive access for health, for STEM, hopefully for research if you want to talk about or fund research on aging and cancer and underserved populations in cancer. Definitely reach out and find Jeannie if you want to see the thread about some of her insanely impressive accomplishments. It is right there on Twitter, and we look forward to seeing you. I see our colleague Juan Soto is on, who's co-leading VentureCrush Americas, which is on October 11th. You can sign up for that. And I want to thank again the VentureCrush team for all of the hard work. Enjoy the summer, and we'll see everyone soon.